Hello and welcome to everyone on the call. Thank you for joining the event. We will start the session shortly. Before we do, we'd like to provide you with some instructions to our Spanish-speaking colleagues. We're providing an option for live interpretation from English to Spanish. The AI platform that we will use is Wordly. We will share this link in the chat box, and we would like you to open it in addition to the Zoom link that you have on the screen. Please note that you need two windows for this, one for the meeting Zoom and one for the interpretation from English to Spanish. You can scan the QR code or use the link that I will share in the chat box. Please select the language that you wish to see. So instead of choosing English here, choose Spanish. I'll now hand it over to the moderator, Magali. Magali, over to you to open the event.
Yes. First of all, good morning, good evening, and good afternoon, depending on where in the world you're joining us today. On behalf of the International Pharmaceutical Federation, FIP, and the Global Pharmaceutical Observatory, GPO, I extend a great warm welcome to everyone who's joining us today, those that are joining us live, and those who will be watching this later. I also like to warmly welcome our guest today, who I will shortly introduce to all of you. We're pleased to be delivering this regional digital event as part of the FIP GPO program entitled How Can Digital Health Support National Pharmaceutical Care Delivery? A regional and global assessment of priorities and challenges regionally and globally. This is a series of 6 regional events that FIP is conducting, and this is the first regional event for this particular topic. Today, we will have 2 moderators. I have the pleasure to be your first moderator. I am Magali Rodriguez de Bidner. I am a professor and associate dean for clinical services at the University of Maryland School of Pharmacy, but I'm also the vice president of the Pharmaceutical Forum of the Americas. With me today, I have the pleasure to be joining this role as moderator with Patricia Clan Acuna, who is a clinical pharmacist in the Hospital Carlos Van Buren in Chile. So Patricia, thank you for moderating this session with me today. You're going to hear more from Patricia later on. We do have some announcements that we wanted to do prior to starting the panel. And we wanted to let you know that this webinar is being recorded and live streamed via YouTube. The recording will also be available at the website at events.fip.org. You may ask any questions, and please we ask that you put the question in the box provided, and we will try to address them as much as we can at the end. Just depends again on timing. We also welcome any feedback you have about this webinar or any others at webinars@fip.org. And if you're not already a member of FIP, we encourage you to do so. Please go to the website and become a member. There are great benefits that you will receive as a member of FIP. And in terms of certificates of attendance, you will be receiving a certificate of attendance from FIP after this event. I also would like to, prior to starting the panels, do some acknowledgement, and we would like to thank Pfizer and Partner for Better for supporting this event today and the Multinational Needs Assessment Program. including these regional seminars that we're conducting today through a generous unrestricted fund. We also wanted to acknowledge the FIP Global Pharmaceutical Observatory team, and you see them listed here. Again, they are doing a great job trying to, again, conduct many of these activities, but also many data assessment projects. Now, it is my pleasure to hand over to you to Farah Aquad, who will tell you a little bit more about the FIP Global Pharmaceutical Observatory. Farah?
Thank you for that, Magali. Welcome, colleagues on the call. In my brief presentation, I'll give you a brief overview about the FIP GPO, which is, as Magali mentioned, the engine room of global pharmaceutical data collection. The FIP GPO will measure and monitor progress towards the FIP development goals. The mission centers around data, intelligence, advocacy, and reporting, the 4 circles that you can see on the screen. We know the importance of data and for data to provide us with evidence which demonstrates impact. So our first task is to collate valid global data on workforce education, practice, and pharmaceutical science. We must undertake comprehensive analysis of collated data to provide accessible, high-quality intelligence, and all this must be communicated innovatively to promote our member organizations' impact on health. This communication will often be via the FIP Atlas, which is our visualization platform for displaying our data and intelligence across the globe. And finally, we will provide evidence-based strategic information, reports, and guidance on the application of pharmaceutical science, policies, practices, and services. You can see some of the programs of work for the GPO on the slide. We will continue to take a tested needs-based approach to addressing data and development goals challenges through the development of an inclusive multinational needs assessment programs, the MNAP. Today's event, of course, is part of this program, and it primarily aligns with FIP development goal number 20, digital health. The FIP GPO Atlas, as I mentioned earlier, is a platform for showcasing our members' needs and priorities supported by the data that we collect from the GPO. It allows FIP to identify opportunities for developing pharmacy with, for, and through our member organizations. The GPO database is the repository for FIP's pharmacy and pharmaceutical science data. It contains data that inform the indicators that will be used to track progress against the FIP development goals. So the FIP DGs provide the framework for needs assessments and prioritizations for member organizations to undertake that are relevant to their national situation. In turn, these priorities can provide each organization with the foundations for mapping the progress and the transformations for their workforce practice and pharmaceutical science. The indicators that we're working on will be a way to measure and monitor progress and transformations for their workforce practice and pharmaceutical science against the development goals via the data that we collect, as I mentioned. And finally, the Commission provides the strategic advice to FIP on the advocacy and the delivery of the GPO projects, focusing on achieving the vision and the strategic objectives throughout member engagement. So for more information about the GPO, please visit our webpage, gpo.fip.org, or click or scan the QR code that I will share in the chat box. I will also share the link in the chat box that you can use to go through the GPO programs. You can also contact us at observatory@fip.org if you have any questions. By that, I conclude my presentation and I'll hand it over to Patricia. Patricia, over to you.
Thank you, Farah. Well, given that context, I'll now give you a quick introduction of the program that actually unites us here today. And this is, well, we all know that substandard and falsified medications along with lack of adherence to medications regimes, pose a threat to public health, right? But not only here, but worldwide. However, it is possible to deliver pharmaceutical care services that address these challenges. How? Well, by using digital health techniques and also digital health approaches. Nevertheless, despite its potential to impact pharmaceutical care, globally, digital health faces many challenges as well as concerns. With this in mind, the FIP and the Global Pharmaceutical Observatory has launched this new needs assessment program that we've already talked about, right? That's entitled, How Can Digital Health Support National Pharmaceutical Care Delivery? A regional and global assessment of priorities and challenges, which focuses on medication adherence and fighting against substandard and falsified medicines. This regional and global needs assessment program will include a series of 6 regional events, culminating in a private global roundtable and summary report. Could you please, next slide, please. So today, regional event aims to facilitate a discussion to assess the ongoing initiatives, drivers, and challenges that pharmaceutical leadership bodies and nations face in integrating digital health into pharmaceutical patient care. We'll emphasize mainly in 2 themes, beginning with medication adherence and secondly, fighting against falsified and substandard medicines. Moving on, in today's webinar, we've already introduced you the program, and we'll now move on to our discussion with these national leaders from the region that will share their experiences and in these 2 main topics. This, as I've already said, the first theme will focus on the integration of digital health into pharmaceutical care services to support medication adherence. And secondly, we'll move on to the second part of this activity that will focus on digital health to combat the substandard and falsified medications. We will also have a quick activity between the themes to engage all of you that are attending this event. So sorry. We will start now with the activity. So Magali, please.
Yes, thank you, Patricia, for your comments. Now we're going to get to the meat of today's event, and we're going to start with our theme 1. And our theme 1 is going to really focus on digital health to support medication adherence. And we have with us today a very distinguished panel that I would like to introduce to you, but also remind everybody that their biography could be found in the chat room. Due to time, we're not going to read them, but they will be there. And let me start introducing our panel. So our first panelist today is Elisa Bernstein, and she is the interim Executive Vice President and CEO of the American Pharmacists Association in the United States. Our second panelist today is Natalia Sancho Vargas, and she is from the College of Pharmacists in Costa Rica, and she's she is the Comprehensive Medication Management Coordinator at the Hospital Clínica Bíblica. We also have with us today Catalina Cana Abasolo, and she's from the Division of Healthy Public Policies and Promotion, Ministry of Health in Chile. And she's the head of the Department of Pharmaceutical Policies and Regulations, Health Providers, and Complementary Medicine. We also have with us today Leticia Caligaris, and she is the Pharmacy Cantinas Militaris, Ministry of Defense Pharmacy at CRIA Clinic. And she's a pharmacist and observer at the CPS Executive Committee. And we also have Timothy owns, who is the digital apothecary. He's an associate professor and a freelance writer and consultant. So these 5 panelists today will be addressing 3 questions for we all. And I'm going to start with question number 1. So question number 1 really wants the panelists to address how their country or their organization is providing any digital health applications or interventions that facilitate medication adherence as part of the pharmaceutical care services, and providing an example for us. So we're going to start with Elisa Bernstein giving us her perspective on this particular question. Welcome, Elisa.
Hi, thank you, Magali, and thank you to FIP for inviting me here and meeting with you all today. Really appreciate it. Yeah, medication adherence, it's a fundamental aspect of what we do as pharmacists. And so at the American Pharmacists Association, and just briefly, if you don't know, our members are pharmacists, and we represent pharmacists in all practice settings or where a pharmacist can be. And so I'm talking from more of a global perspective in terms of how we do things here in the United States. So we look at medication adherence as part of an overall medication management strategy. And so it's one aspect. We've got a patient care process of all the questions and interactions that you go through when you're looking at a patient, assessing a patient, and working with the patient on the patient care team. So part of some of the resources that we have for that is motivational interviewing, which is really important to ensure outcomes. We have a resource on appointment-based strategies, which is getting the patient in and really having that face-to-face opportunity to ensure adherence. We work very closely with other organizations that develop evidence-based standards in order to ensure compliance and adherence. The Pharmacy Quality Alliance is one of those organizations here in the United States that we work closely with. And then we take some of those standards and then create also some resources specific to disease states. Like we have one on hypertension and diabetes, and these are resources that are on our website. So I'm just kind of giving you this background of some of these strategies and resources that we have. But then part of that, how does the digital aspect fit in? Well, whether you're a large chain pharmacy or a small or independent pharmacy, a lot of them use texts, apps, emails, and other types of push technology to remind patients about their medication, remind them of their appointment if it's an appointment based. Sometimes it comes out of the electronic health system, the EPIC system that we use here in the United States. So there are a lot of different strategies that are used, but there is no one that's mandated. But one of the things, and I'll finish up, one of the things that's really critical is the federal agency that works on the CDC, the Center for Disease Control and Prevention, is very proactive in this area and partners with APHA, academics, and others in order to really provide some of that evidence-based resource data and resources in this area.
Thank you, Lisa. And now we would like to hear from Natalia.
Hi, everyone. Thank you for the opportunity to be here with you. So in Costa Rica, we have basically 2 sectors. We have the private sector and the public healthcare. So Costa Rica does provide interventions that facilitate medication adherence as part of our pharmaceutical services in both healthcare sectors. So regarding the public healthcare, they developed an app with features such as medication tracking, immunization registry, health measures such as blood pressure, weight, oxygen saturation, glycemia, INR, appointments, blood tests, medical images, diagnosis, etc. This app is linked to the electronic healthcare record of each patient with the social security organizations in healthcare. So this means that every primary care clinic, health area, regional and general hospital has access. This was possible thanks to a technological management program on a national level. There was a reform of the electricity and connectivity infrastructure in all the social security health centers to provide the clinical support decision-making system. There was a reorganization of the pharmacy service at the institutional level with the pandemic, and there was the use of electronic prescriptions, the use of digital tools such as SharePoint to communicate like between floors in the hospitals, and the pharmacy also was strengthened because the pharmaceutical programs, for example, in pharmaceutical care, they function normally. Instead of going to the appointments face-to-face, they started doing care via telephone. Also in pharmacies at the social security healthcare, they function as a collection center for the whole hospital. The physician gave their digital appointment, and then they programmed the next appointment. They prescribed medications or their exams and sent the package to the pharmacy. There the pharmacy arranged the patient's medications and mails the like the whole package with the medications, exams, etc. Via Correo de Costa Rica, that's like the Costa Rican email, that is a public organization. And then they got there to the patients' homes, to each of their area. So that was like a strategy that they did so the patients could stay adherent to their medications, even though there was the pandemic going on. Also regarding the private healthcare, the hospital I work in, it's Hospital Clínica Bíblica. We send customized short messages to the patients, reminding them to pick up their medications or their refills. We make a coordinated dispatch service, dosing reminders. Our hospital also has been working on an app for patients. For now, it helps patients with health measures and appointments, and it's also associated with medication adherence. We also work with free apps that are available for everyone at the app stores. And we also have our comprehensive medication management program providing telepharmacy services via telephone, WhatsApp, email, Zoom, Microsoft Teams, whatever the patient feels comfortable with. So by doing that, we give them pharmacotherapeutic follow-up education. We implement clinical interventions with the healthcare team, and we also provide express medication to all parts of our country. And it's duly certified to comply with temperature, humidity conditions as it's been appropriate for the patient to get the medications in the right way.
Thank you so much, Natalia. Very informative. Now I would like to ask Catalina if you can address the same question.
Okay, good morning, everyone. I'm pleased to share this meeting with all of our colleagues and students also. However, I will answer in Spanish this time. Bueno, buenos días a todos. Un gusto estar con ustedes. Comentarles que en Chile el Ministerio de Salud ha desarrollado un sistema que le hemos llamado el Sistema Nacional de Receta Electrónica, que es una plataforma mediante la cual los distintos profesionales de la salud que prescriben medicamentos, médicos, odontólogos, matronas, pueden realizar las prescripciones de medicamentos a través de un sistema que tiene características bien particulares. Se considera de alcance universal, es gratuito, tiene características de trazabilidad, ¿cierto?, que permiten entonces seguir una prescripción desde que se realiza por parte del profesional hasta que se dispensa el medicamento al paciente. también tiene características de ser interoperable. Lo que se busca entonces es que a la medida que este proyecto se desarrolle pueda integrarse con aquellos sistemas informáticos que pueden haber desarrollado los distintos establecimientos de salud, ¿ya? También se considera robusto, dado que garantiza la confidencialidad de los datos, ¿cierto?, de las prescripciones y por supuesto del paciente y de quien prescribe los medicamentos, y permite al farmacéutico poder acceder a esta información, y buscamos que en el futuro sea una herramienta para que los profesionales farmacéuticos puedan colaborar, por ejemplo, con la optimización del tratamiento, con la prevención de errores de medicación, con la prevención, por ejemplo, de reacciones adversas, interacciones farmacológicas, etc. Cuando decíamos que es de alcance universal, es porque cuando esté en plena operación, este sistema nacional debería integrar a todos los actores del sector salud, ¿cierto? Instituciones públicas, privadas, en todos los niveles de atención, desde la atención primaria de salud o el ejercicio independiente de los profesionales de la salud, hasta los establecimientos de salud de mayor complejidad. Esa es, digamos, la principal herramienta que desde el Ministerio de Salud se ha puesto a disposición de la población, de la comunidad completa, como herramienta tecnológica digital en relación a la prescripción de medicamentos.
Thank you, Catalina. And just very briefly, Catalina, for those English-speaking colleagues, Catalina was describing a tool that the Ministry of Health has implemented in Chile that is an electronic system. And it's an electronic system for prescribing. And the goal is that all the members of the healthcare team and all the sectors within healthcare could really utilize this tool to optimize drug therapy, to help with the ability of the pharmacists to monitor, decrease side effects, and really optimize and decrease adverse events and misadventures of drug treatment. Thank you so much. And now we're going to move to Leticia.
Hello, good morning, and thank you for the invitation. Well, I'm going to talk about an app we have here in Uruguay. The name is Coronavirus UI, and it's an app with born very small and now it's very huge. And the idea for this app was born less 10 days after the first positive case was confirmed in Uruguay. At the beginning, the app was used to provide general information about what was SARS-CoV-2, as well as to prevent the collapse of the health service in terms of medical consultations. So what we do at first was connect the users with their health service using information who was available at the Ministry of Health. To give you an idea, there was only 300 cases, and we have 50,000 queries a day for in this app. As a positive case increase, it was necessary to implement telemedicine in this app, so the patient can be contacted by the doctors in this app. The next step we take was to contact tracking. So if I was with someone who have COVID, the application let me know that maybe I was positive. Then in last year, there come another challenge, and it was to organize the vaccination schedule for all the people. So we will use a logistic system that evaluate each one of the requests, and with the restrictions and rules that which was given with by the Ministry of Health. So, for example, in 1 week, we have 1 million people registered to have the first immunization. So the app put the first group at first and give some a kind of order in the all of people. Until that moment, we don't have even enough for the demand for the vaccines. But with the application, we know how many vaccines we have to move for the different parts of the country. So we have an optimization of the vaccines. And then we have in last year, at the end of the last year, the community pharmacies can interact with this app and because we can do in the pharmacies the COVID test. So in the pharmacy, we can say to the patient the results and say the ministry and say the government what was the result of the COVID. So this is what I think is a very huge step for the community pharmacy to be integrated in the system. And that's all.
Thank you so much, Leticia. Let me make a quick announcement, colleagues. Catalina's answers will be posted in the chat box in English. So even though she may be speaking Spanish, you will have access to her answers. I just wanted to remind everyone. And that brings us to Timothy.
Hello, everyone. So I'm probably going to come from this from a little bit of a different direction. I think I'm from the United States, so we see a lot of different technological growth that's occurring here, but I think it's also going to be widespread, at least within the next decade. Things I struggle for as an educator, as a subject matter expert in the digital health space is that there's definitely rapid growth. We're seeing a push for mobile phones, for smartphones to use apps to integrate with data. And I think that's the question is data. What do you do with this information? We primarily in pharmacy focus on trying to use this data to stop prescription abandonment. We want people to pick up their medications. We want them to take them. But the data we have to how they take them is very, I would say, very subjective at this current point, right? Like you can maybe look at claims data, you can look at pickup data, but I don't know how someone uses their medication in their home. And I think that is a shortcoming at this current time. This is the reason why we're seeing technology like this. I'm going to showcase some things just so you want to watch my screen. We have things like smart pill bottles that are now popping up. This thing makes an alarm go off and you open the pill bottle. And when you open the pill bottle, ergo, that means someone probably removed the medication right and took it. We actually now have bio-ingestible sensors. You swallow medication, it sends a ping and it says someone swallowed the medication as well as too. So it's like oral therapy. We have items like inhalers. So you put an inhaler, meter dose inhaler inside, and there's a sensor on this. So every time you use this and use an actuation, it shows that you inhale the medication. They are even getting more developed. They can show how many liters of inspiration you have. They can say, I did a bad inspiration, I failed the inspiration, or I did a good inspiration. We're even getting to the point where you can get little sensors like this, and you can put this on the back of an insulin pen, for instance, and it tells you how much insulin the person's using throughout the day. So this sounds interesting, right? This is technology. That's cool. But what's the application for it? And this is where I come back for education. If we are moving towards an environment where our future learners and pharmacy practitioners are working in an environment where we have this continuous data, where you have this information, how do you use it to help guide care? And I think what will end up happening is we move away from just talking about medication adherence, and we'll move closer and closer to medication optimization. Not just you took the medication, but did you use it well? Do we need to educate you further? You're taking your medication correctly, but you're still not meeting your therapeutic endpoints that we want. Your blood pressure is still high, your asthma is uncontrolled, you're still having exacerbations, your weight is up with heart failure. So we take all this, remotely monitor it, and we're moving towards a point where how do we guide that care based on this information? And that's currently in the United States, like that's some big tactical points that we're taking on. Lisa, I think we've had, well, some members of APH are having this conversation grow as well, and within our own American Association of Colleges of Pharmacy trying to guide this thought process. So this is stuff that we're seeing. This technology may seem advanced right now for here, but I think what we'll see is at least within the next decade, a lot of the stuff start coming downstream across the world in certain other areas. And it's just something to keep aware of at this current time.
Thank you so much. I want to thank all the panelists for providing us with some overview of what's happening in your countries. Now I wanted to move to the second question, and is, Could you tell us what are some of the barriers that you're seeing for the integration and adaptation of digital health interventions, and what approaches pharmaceutical care services to support medication adherence? So again, moving now to some of the barriers and challenges that you're seeing. So Elisa, we'll start with you again, and we go through the same rotation.
Great, thank you. Yeah, you know, what Timothy was just describing, and it is all great, but that costs money, and who's going to pay? So I think the biggest barrier is the cost of the technologies and the integration of the technologies, because at least in the United States, you know, that the money is very slim, and it's hard to really justify that. But that's where data comes in doing the studies to demonstrate the benefits. So I think cost is one of the barriers. The time it takes to collect that data and to do the integration and to talk with the patient. But I think that if pharmacists are willing to take the time, the problem is that right now, during COVID, post-COVID, there is not a lot of time that pharmacists have, because it's just boom, boom, boom. And at least in the United States, pharmacists are burned out, and from all that's been happening. So I think that's one of the barriers. And another one are the privacy laws. So it may be that the patient isn't necessarily in a good position to be compliant or adherent, but their caregiver or a family member is. And so there are privacy laws that you need to make sure that others have access to your information. You can't just give access. And so, and some of that data that Timothy was talking about is accessing that data is very difficult. And, you know, you could anonymize it, but even getting that data is hard. So I think some of the key are the time, the cost, and the laws that prevent the implementation. And unlike Catalina, we don't have a national system, so we don't have the government who is willing to pay. So that's wonderful that you do.
Natalia?
Hi. So the challenges in Costa Rica, well, they're a lot related with money-wise also. So it's also related to sustainability, and the patient care also. It's been addressed within the system with various actions. They require progress in a more articulated way in conjunction with the different actors that participate in it. Mainly the continuity of healthcare implies an immense exchange of information between the various actors, like, for example, doctor, laboratory, pharmacy, medical records, and other healthcare professionals. And if this information is fragmented into different repositories, its usefulness will be limited. So it becomes critical to maintain a constant flow of information. Adherence is a challenge in every country, regardless of the income, and however limited resources and shortages of qualified healthcare professionals are additional barriers to adherence. It's also critical that policymakers, program managers, healthcare providers to consider account for non-adherence in planning, implementing the caregiving of the patients, particular populations that are also at increased risk for medication non-adherence include, like, for example, the elderly. In Costa Rica, there's an increased burden of non-communicable diseases such as cancer, diabetes, cardiovascular disease, with already like an immense account of our patients are already like coming into the elderly ages. So we've have a like how can I say it, like we've had like a how can I say it, like our people are becoming like more old within the pass of time. There's not like enough births, so there's nothing like to maintain the social security pyramid. to sustain the health security healthcare. So it's been like a huge burden for us in that case. There's multiple conditions in these elderly patients, polypharmacy, multiple providers, physical and cognitive issues with these patients. Also, we have like also in risk of non-adherence, we have the children and the adolescents that are or either they need like an adult to be in charge of their medications, or for example, there's the adolescents that they're becoming with physical, social, and psychological changes. And also we cannot, we have to address also one of the most important populations that are the marginalized, that they face economic, social, and stigma related barriers to adherence also. Between the opportunities, do we have to talk about the opportunities already, like to see what we can make, Magali? Like to help?
Yeah, maybe
Or
we
later?
leave that for,
Okay.
we leave that for our third question. Maybe we
Okay.
can wrap it up. Okay.
Perfect. So that's our barriers and
Yeah,
challenges.
thank you. Thank you, Natalia. Now, Catalina, and a reminder again that the answer in English will be in the chat.
Okay, thank you, Magali. Bueno, yo creo
I think we're having some sound issues. Catalina, we cannot hear you. It froze.
Magali, I think we'll.
Okay.
Yes, Katerina, can you try speaking again with your video off, please?
If not, we could go to Leticia and then come back.
Sí, perdón, no puedo reiniciarlo.
Sí, 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 Catalina.
¿Me escuchan bien, cierto?
Sí, ahora te escuchamos bien, muy bien, sí.
Ok, sí. Bueno, decía que los costos, ¿cierto?, de la tecnología es probablemente lo que estamos coincidiendo en cuanto a cuáles son las barreras. Ahora, respecto a este proyecto que es el que yo hacía mención del Sistema Nacional de Receta Electrónica, quizá el principal desafío que tenemos que enfrentar es la capacidad de interoperar entre nuestro Sistema Nacional de Receta Electrónica y los desarrollos informáticos que han realizado cada uno de las instituciones de salud. Ese es un trabajo de largo aliento y que dentro de las características con las cuales se ha definido el sistema y que busca tener un alcance universal, es quizá el que nos ha significado mayor dedicación de tiempo y nos va a significar mayor dedicación de tiempo. Antes de que existiera esta visión de tener un sistema nacional, cada institución fue desarrollando sus propias aplicaciones con una arquitectura informática que obedecía a las necesidades de esa institución, a veces una ficha clínica, ¿cierto? U otro tipo de funcionalidades. Sin embargo, al contar con un sistema nacional requiere necesariamente que hablemos en un lenguaje común. Y eso a veces es más difícil de lo que parece. Sí comentarles que tempranamente en Chile se hizo una definición que es para lograr que cada prescripción sea trazable y podamos tener datos y estadísticas comunes, tuvimos que definir que cada uno de los productos farmacéuticos, cada uno de los medicamentos debía codificarse en base a lo que le llamamos la terminología farmacéutica chilena, que es el código mediante el cual se va a emitir cualquier prescripción. Entonces, eso ha significado también el aunar voluntades y poner de acuerdo a distintos actores del sistema de salud. Por lo tanto, y en resumen, el principal desafío para nosotros es lograr que este sistema que busca alcance universal pueda interoperar con todos los actores del sistema de salud. Eso es.
Thank you so much, Catalina. And then Leticia?
Well, the cost, obviously, of these things are very high, but I want to say a little thing that in Uruguay, the cost from the development of the app was zero, because the professional who worked didn't take money. So we all work together between the government and the private enterprises. Then we have some what we have. The barriers are inherent to technology, because they have to be available 24/7 days a week. The high cost, but in our case was very low. Guarantee the information security of the person, because we are talking about special things of some persons. And the technology have to hold the demand that would we have. For example, we have 1 million acts for vaccination in only 1 week. The second is the target audience. We provide, we have to provide friendly accessibility. For example, we have to think in web requests, requests from the app, a chatbot in WhatsApp, or maybe a call center. Maybe an old person wants to hear a voice or not to read in a telephone, or talk with a robot in a chatbot. The third one, I think, is regulatory, so that we have to have a strong law that apport a frame to the digital health.
Thank you so much. And Timothy?
Yeah, from an educational standpoint, like what we're trying to focus on, I think right now is in the United States, trying to figure out, where do pharmacists and where does our workforce go with all this stuff as well. That is a question, as Lisa mentioned, like we are having a burnout workforce. There's some digitalization that's occurring to help sublimate some of that, for good or for ill, at the end of the day. But there's other things that will probably go on. We've done well with research showing that pharmacists can do a lot of clinical duties. The biggest issue that we've had is that in the United States, much of our workforce and much of our billing for insurance is through payers. Really prevalent right now is high deductible healthcare plans, for instance. So we have a lot of our patients are now turning to online pharmacies, direct to consumer things, because it is cheaper for them than going to even through their insurance. This makes data fragmentation even harder. Even if I'm talking about medication reconciliation, are you buying your medications from an online company? Are you buying them at, like, say, CVS? Are you paying cash price at Walmart? This is very variable. Some things that we're hoping that will help is CMS, or Centers for Medicaid and Medicare Services, are hoping to implement better interoperability of data across the spectrum, but I don't see that taking off for another 5 years, to be quite honest. Further with that is with the payers evaluating different technology and what is the value. I think for us, at least pharmacists in the United States, will have to determine where do we fit into a spectrum of changing dynamics of how care is delivered. Where should we go? What should we do? What's interesting is that CMS, again, has implemented new CPT codes or billing codes for providers to actually monitor medication adherence. That was released in the past 24 months. What's sad for us, though, is that pharmacists are not able to bill for that. So despite us talking about different technologies and things that can help out for that, our pharmacists in the United States, who should be monitoring medication adherence and being able to justify that service and that cost, cannot at this current time. And it's something that we'll probably have to fight for within our country for a while right now. I think once we get to there, though, by engaging with the technology and having the pharmacists able to be a reverse for those things, we can tackle different things like social determinants of health. We can overcome our healthcare deserts that we're now facing and have ourselves more upfront. We are the most widely accessible healthcare practitioners in the United States. The issue is scalability of our services that is demonstrable in a meaningful financial way to ensure that we're worth having around for that reason. That's why I come back to this technology, hoping it can override some of those things, but it is difficult. And this is just a snapshot, I would say, for right now, what we're facing.
Thank you so much. Thank you to all. And that takes us to our third question and final question. And it really relates to what are the enablers and drivers to integrate and mobilize digital health interventions and approaches in pharmaceutical care services to support medication adherence. Elisa?
Yeah, hi, thanks. Yeah, so That's a really good question, because there's those barriers that we just talked about are huge. So how do you overcome them? And particularly, the cost of implementing and that will to implement it, because pharmacists want to be able to use some of these tools and resources. I think one of the aspects, at least in the United States, so we have an extremely complex payment system for healthcare in the United States. That some is government, some is private, some in terms of how medicines are paid. One way that payers across the spectrum are trying to cut costs is by actually measuring adherence as a metric. So looking at they look at different metrics of performance for pharmacies. And if a pharmacy is not meeting a metric, they may not get paid the full amount for what was provided to that patient, or even the cost of the drug. So it's really creating an incentive to put in some of these programs, digital solutions that are not time consuming for the pharmacist, but are more automatic, because pharmacists are not getting paid, and are oftentimes are getting less than the cost of the medicine. So I think one of the key drivers is this metric. But that's why, going back to what I said at the beginning, is having evidence-based, consensus-based standards that everybody is on the same playing field, that is at least a driver in order to make sure that all of these measurements are done from a very thoughtful way. I'll stop there, because I think that's kind of one of our biggest drivers here.
Great. Natalia?
Thank you. So also with what Elisa was saying, I think also it's necessary to move towards a more personalized health model that improves quality and equity and sustainability of like the adherence we give to the patients. Given that fact, there's like, for example, there's national barriers that we have in Costa Rica. We need more advances in biotechnologies. The United States is really strong in those technologies. In Costa Rica, we don't have like the access that you guys have still. We need more strong systems to monitor and improve medication adherence. We need, like, for example, well, in some countries, like, for example, I think in Europe and in the States, they have more of like a multidisciplinary approach. We still have inadequate communication among healthcare providers. So we need to to make those connections stronger. There's also like the need to follow guidelines, that everyone like sticks to the guidelines and works according to the guidelines and implement them, follow them. With the emerging of the technologies, it's also really possible to overcome these obstacles, establishing like a renewed health system with a greater quality, equity, and sustainability. And I think it's like that's like the common denominator for this transformation. According to the personalization of health, we have to implement models that are more center-based to the patient, helping the communities. And I think those are like the principal like things we can do. We can promote effective patient-centered communication in relation to medications, maintaining update professionals with knowledge and skills to support medication adherence, understanding the patient's current circumstances and previous experiences, beliefs, and behaviors to promote adherence, and also support the patient by taking their incentivizing them to take their medications and determine which is the better strategy for them to get their medications. We also have the social security gives the medications to the patient that's like affiliated to the social security, but we also have the private sector, and the private sector has like really expensive medications. So there's like a whole thing with that to help patients have adherence, to help like prescribe less complex treatment regimens, and I think improve overall access to services.
Thank you so much, Catalina.
Sí, bueno, creo que mis colegas han entregado puntos de vista muy interesantes, cada uno desde su realidad. Yo creo que en el caso nuestro, desde la perspectiva de lo que ha pasado en Chile, la necesidad de mejorar el acceso a medicamentos como una política pública ha sido central para que los tomadores de decisión, los policy makers, en primer lugar, apoyen el desarrollo de iniciativas como la que yo describí. Eso es lo primero y afortunadamente eso se ha mantenido, ¿ya? Como política pública. Ahora creo que también la pandemia de COVID-19 también ha relevado lo que es el desarrollo y la importancia de tener plataformas digitales o electrónicas mediante las cuales se entreguen servicios de salud a la población. Si hay algo que encontrarle de positivo al haber experimentado una pandemia, es que aceleró o empujó el desarrollo de tecnologías, ¿ya? Eso en el caso nuestro, para lo que es el sistema de prescripción electrónica, ha sido vital. Y lo otro es también cómo se ha ido ampliando la utilización por parte de los distintos usuarios de aplicaciones móviles, de incluso plataformas de adquisición de productos y servicios. Eso ha ampliado, ¿cierto?, o ha reducido la brecha en algunos casos de acceso a las tecnologías, ha facilitado que las personas se familiaricen con los sistemas y yo creo que eso ha sido digámoslo así, un incentivo a poder desarrollar plataformas como por ejemplo esta de prescripción electrónica, entendiendo que es un proceso. ¿Cierto? Escuchaba lo que mencionaba, ¿cierto?, Timothy, respecto a la posibilidad de ya implementando servicios farmacéuticos, de que pudiera estar esto asociado incluso a una remuneración o a un incentivo hacia al farmacéutico. Nosotros creemos que a la medida que avancemos en un sistema robusto, necesariamente el rol, en este caso del farmacéutico, va a ser fundamental y esperamos que este tipo de políticas vayan sumando cada vez más estas voluntades. Todo en pro, ¿cierto?, de optimizar los tratamientos farmacológicos de nuestros pacientes.
Muchas gracias. Thank you, Catalina. Leticia?
Okay, I have a little thing more to say because all the panelists was saying the list I have in mind. But in our case, at the end of last year, we can be connected in this app and be connected with the ministry and with other service of health. So we are going to implement a pilot for vaccination in community pharmacy. So we take this as we have to run and we have to know that we can be connected so we can do another thing. And we think that we can vaccinate in community pharmacy and can write in the history of the patients. So that's what we are going to do.
Thank you so much. That sounds really exciting. Timothy?
I think a lot of what's been said is like, I think in general is what we're seeing a lot across the whole board for professions. So I really would follow all that. I think the only thing that would be different for me, like in the United States, some things I'm tracking and like just following is that we have a lot of untraditional factors that are like making inroads into our profession that we never expected in the past. I never thought a company like Amazon, Apple, Google and stuff would want to care about these types of things. If you follow like Apple, they they just announced that like on their smartwatch, they want to bring into a way to track your medications and give drug information and drug interaction reports on your smartphone. And I think it's that kind of stuff that's now, I'm taking a step back. It's like, are those allies? Are they competition for pharmacists? How do we deal with all this type of stuff? So from a regulatory national standards and everything else, I think government's going to do government stuff, regulators can do regulatory stuff, and us as pharmacists will work with our traditional relationships. I'm just trying to figure out, what does that mean for the future in terms of other people that want to come in to deal with pharmacy related things such as medication adherence and how they may change things up. Maybe they think outside the box that we haven't, or maybe they can make things worse at the end of the day. I am not sure. And these are types of things I'm trying to figure out right now. I don't have a good answer for that, but I think that's just an example of small geopolitics that we'll probably see roll out in different areas as digitalization of care takes off. I think we'll see that in some other countries. I know India is one I've seen that being pushed. I know some parts of the EU that's being pushed. So United States being a microcosm may be demonstrable to how some of these aspects may spread out as these ideas take place here, at least.
Wow, thank you to all the panelists. This has been really, really informative and really give us kind of a small window in what's happening in the region. And I just wanted to share that, this is something that is going to be really important to pharmacy practice, but also pharmacy education. And as somewhat at the University of Maryland, I direct a e-health center that really what we do is provide this type of care and try to engage our students in getting in the forefront of digital health. I share many of your barriers and challenges, but also I share the optimism and the bright future. I think this is an area that we all should look forward as practitioners, but also as educators, because it's unlimited. And like Timothy said, really defining what is our role, not only as a clinician, but what is our role to educate the future pharmacists. So again, thank you so much. And now it takes us to an activity where you, the participants, will be engaging with. So I'm going to pass to Patricia, who's going to work with you in an engagement activity. So thank you so much to all. And we'll be back for question number 2 a little bit later.
Well, after this interesting conversation, we would like to hear what you, actually our audience, thinks about what are the main challenges to implementing digital health in pharmaceutical care services. That's why on your screen, you can click what do you think these challenges are. So the first option would be lack of regulatory models, policies, and strategies. Let's say lack of regulations to ensure safe and effective use of digital health. The second option would be economical and financial concerns. This means costs for digital health implementations. It's mainly high. You can click also the patient confidentiality risks and safety, mainly the risks regarding patients' information security. The fourth option would be variable technology literacy and accessibility in the community. In other words, the patient's technology literacy varies, right? And not all communities know how to use or have access to these technologies. On the other hand, you can say that these challenges are mainly because of lack of professional learning and training for pharmacists in digital health, or maybe because lack of evaluation of mechanisms and monitoring of digital services. Let's say lack of monitoring tools and mechanisms to evaluate the use of digital health and its effects. And lastly, maybe you think this is because of the lack of interoperability of systems, as some of our panelists have mentioned, right? And so, yeah, we want to know what do you think. So we'll give you a little while to see what it's people saying about this.
Patricia, can I add that our audience can choose more than one option if you wish?
So you're right, Farah. You can choose among your 3 top options.
Okay, Patricia, I'm gonna end the poll now and
Okay.
share the results.
So the tendency is quite clear, and mainly our audience thinks that these challenges are maybe because of the lack of regulatory models, policies, and strategies. Yeah. And in the second place, variable technology literacy and accessibility in the community. So this is adding what our panelists said about costs and some other issues. So yeah, we have some variable ideas about these challenges are. So Magali, in honor of time, would you please introduce us the second theme?
I'd be happy to. So now, as we stated, we had two themes going on in this particular session. So we're going to move to theme 2, which is really dealing with digital health to fight substandard and falsified medicines. And I asked the panelists to please turn on their camera. And as we did in theme number 1, we're going to go one by one, and they will address from the respective region the particular questions. So Elisa, you are again our first panelist.
Great, thank you. Really appreciate again the opportunity to be here. So I'm going to talk about fighting substandard and falsified medicines in the United States. Here in the United States, substandard, counterfeit, falsified medicines, it's rare. We have a pretty good drug supply chain, but it still happens, usually from mischief that's happening outside of the normal channels. For many years, almost 20 years, FDA and the stakeholders have been working together to try and put measures in place to really lock down that supply chain to ensure that there's transparency and accountability, what's in the supply chain, who is in the supply chain. And for many, many years, there was voluntary measures. People were trying to implement some of these digital solutions using RFID, like radio frequency ID, or some other means, but voluntary didn't work because it costs money. And there was no way of really standardizing how products move through the supply chain using the different technologies, because you can't all have different technologies. So in 2013, the US Congress worked really closely with the FDA and other supply chain stakeholders, the manufacturers, the wholesalers, the pharmacists, and solution providers, and came up with a law called the Drug Supply Chain Security Act. And just as a sidebar, so I actually worked at FDA during this whole time, and in the development of this law, as well as the implementation of the law before I came to APHA. And so the aspects of this law are two parts, and one is to create an interoperable electronic tracing of products down to that package level by 2023. So this was passed 9 years ago. Next year, this system is going to be fully in place. And the way that the law was created, it was a stepwise approach. So there were different requirements that were put in place throughout the last 10 years or 9 years in order to build and create this fully interoperable electronics way of tracing products. And it's a way of being able to identify what's in the system, who is in the system, and then promptly respond when a suspect or illegitimate product is found. And it does help with recalls. So if there is a problem product in the supply chain, it's a way of actually getting it out of the supply chain. And another part of it was establishing national standards for wholesale distributors. And so that part of that, who is in the supply chain, because for many, many years, it was that middle of the supply chain in the United States where the problems were occurring. So on the next slide are a little, I'll tell you about some of the aspects of that law and what's being put in place. So it created a standardization of who is in the supply chain. So only authorized trading partners with valid licenses or it could be part of this, part of our national supply chain. So when it comes to pharmacies, which are actually called dispensers under the law, they have to be licensed by the state. And so we don't have a federal pharmacy licensure system here. It's the state where you're doing business. So it may be the state where you're located and the state where you're sending the product. It also created these requirements to know where the product is and when it moved and exchanged hands. So there's this transaction documentation that is required to be exchanged between authorized trading partners. The what's in the supply chain, that it's really being able to identify if you have suspect and illegitimate product. And there's guidance and other information and resources for supply chain stakeholders to look at those red flags of whether they have a suspect product or a falsified product or a substandard product, and then requirements that they need to do to quarantine that product and investigate if in fact it is a falsified or substandard medicine. And then another key part is, so each package has its own license plate, its own serialization. So having a product identifier on with a 2D barcode on all prescription drug, well, most prescription drug products. And as of 2 years ago, you can only buy product in the United States that has the serialized number on it. So going to the next slide is just an example of the standard of those product identifiers on prescription drug packages in the United States. So there's the national product code, then a serial number. Its serial number is individual on every package, so it could be up to 20 numbers. Then the lot number and the expiration number, and it's all in this 2D barcode. And the supply chain wasn't using 2D barcodes when this law was passed. So this law has driven the supply chain and manufacturers to start putting them on and using it, as well as pharmacies and others in the supply chain to buy the technology in order to read this barcode. Going to the next slide. So that's what the supply chain does. I wanted to add something else, another type of technology that's used. This is not used by the supply chain. This is used by the regulators. So FDA and our customs officials at the border. They actually developed a handheld portable device that as products are coming in the borders, using different types of technology of fluorescence and absorbance and all these other highly technical things in order to look at whether the packaging or the product is falsified. So it's pretty cool because each year or not each year, as the year has progressed, it's become, they've increased the technology in order to really more readily and easily identify products these products that are coming into the United States. On the next slide. The other key piece for pharmacists and others in the supply chain is you may find something that's illegitimate. So if it's substandard or falsified, that's considered illegitimate. And you're required to notify the US FDA. And there's a form, there's a way to do it online as well that has basic information. But not only do you have to tell the FDA, you have to tell your trading partners. Who did you get it from? Who did you sell it to? So that there is more openness in the supply chain and everyone together will do the investigation of whether, in fact, there is falsified or substandard product in the supply chain. We'll go to the next slide. So that's what they're the technology, but what are the barriers of implementing it? It's like pulling teeth to get the supply chain to implement this. As I said, for many, many years it was voluntary. Now there's a law in place, but actually implementing this law, even over a 10-year period, has been very difficult. So in terms of time, so as I said earlier, pharmacists and pharmacies, they're busy. There's a whole lot going on. And there's a lot that they're doing in order to just keep their door open and be financially have sustainable. So to put in place measures that go into effect in the future, they have no time for that. They're just looking at now, what's happening now. So that's part of a barrier. And the cost. The government's not paying for this. And as everybody along the way in the supply chain has to put in place these measures. So as the drug moves through the supply chain and each touch point in the supply chain has these measures in place, it's going to cost them. And what does that do to the cost of the drugs too? Because as you can't just bury it into the cost, because it's right now it's not included in terms of what you will be reimbursed. So everybody has to pay for this themselves. There's a lot of skepticism, as I said, that the supply chain in the United States is relatively safe and secure. And so people are saying, well, why? Why do we need this? I buy from legitimate wholesalers. I don't need to put this in place. So they're very skeptical about why they need to do this. Politics, everything in the United States and politics gets involved. So I'm just going to stop there, because you probably have seen some of the politics that happen here in the United States. So that happens at the state and federal level. The other problem and barrier is not having a clear roadmap. So the law was passed, and FDA and stakeholders have to work together to develop that roadmap to implement the requirements, which includes all the technology, and putting all of the guidance and regulations in place has taken time. And right now there is really no clear roadmap, even though it goes into effect in next year. And so next year, basically every product is going to have that 2D barcode. And instead of passing that transaction documentation by paper, it's all going to move electronically behind the scenes. And so FDA, in fact, just a few weeks ago, published a standard that they say that the supply chain needs to use or would use, and that's based on a GS1 system. So that's just a draft. So there's no clear-cut standard. The supply chain may be moving in that direction, but it's not a lot of time to put in place measures. And then who owns the data? Nobody wants to share their data. So I know who my business partner is. I know who I'm selling it to. There's no real clear visibility across the supply chain of where products are. So if you need to do an investigation. So going to the next, the third question is what is the driver? I don't have a slide for that, because the driver to implement this is that the law, it's a law, and the law has penalties if you don't follow it. So the driver is you don't want to pay a huge fine, and you don't want to go to jail. And that's really a big part of what is driving the supply chain, because absent that, there's a lot of stakeholders who likely will just say, let other people worry about this. I'm going to give you finish with just a very recent, relatively recent case study that shows that Gilead, there was counterfeit or falsified HIV medications that were in the United States, were found in the United States, that were actually found in pharmacies. But how did they get there? How'd they get there? Well, they got there because the pharmacies were not buying from authorized trading partners. And the part of the law that went into effect way back 1 year after the law was passed was you can only do business with authorized trading partners. So these pharmacies were doing business with unlicensed wholesalers. So that the product got into the supply chain, It wasn't through outside of the people who are supposed to be in the supply chain. And what these counterfeiters did is they took legitimate bottles, opened it, and put in fake product, and then got it into the supply chain. And so that's really why it's real. And there was falsified information as well that went along with it. And so as part of the incorporating this law are those red flags of when you might have some people or some product in the supply chain that's falsified and substandard. And there were a lot of red flags in this. And the number one was not doing business with someone who is licensed or authorized. I think that's my last slide, and I think I'm running out of time. So I'm going to stop there and turn it over to Timothy. Thank you, Magali.
Thank you.
I'm going to go fast then in this case, just because I know the time is here. So let's progress as we go to the next slide. A lot of the points that Elisa basically went over is true. I mean, there's different technology that is coming out, and some of them that stand out to me is like RFID, using better information databases. Some people are even going to like edible radio frequency tagging systems, such as a fluorescence that we saw, so that you can scan and say, hey, it has a tag that was put in production. If it shows up and when you shine a light on, it has a tag in it, then you know it's a real drug that's produced by a manufacturer, versus if it doesn't, then it could be fake. Barcoding, I think, is probably the easiest one for us to roll out this current time. A lot of the other stuff that's going on, people try and play with spectral imaging, camera-based assessments, I think cost is going to be the biggest issue. Who wants to take that on? The other one I hear people talk about all the time is like blockchain end-to-end encryption and such. This is something that has come up over and over again. People are talking about moving from Web 2.0 to Web 3.0, the use of NFTs or non-fungible tokens and such. Quite honestly, I'm going to put that for like 2050s plus. That can be someone else's problem as far as I'm concerned. I don't see it right now for us, just from the fact that scalability and cost is just too high. And I think pharma is just gonna be like, if it works, why break it right now? We have to see other cases to actually justify why would we want to change this. So let's progress. Next, yeah. So barriers and challenge, I think, is, as Lisa pointedly put it, is going to be cost. What is the value proposition at the end of the day? And within the United States, I think for us right now, there are several things that may be going on that could lead to possibility more divergency from our chains, and that could be if people start trying to go through the gray market or different wholesalers to get cheaper drugs to sell it more lean. So the pharmacies, I think, are going to have to be cognizant of where do they get their drugs at the end of the day. Some things that do come up that is also becoming a question that I'm seeing is even some devices, combination products, inhalers, and biologics that are used for high cost conditions. We are seeing people trying to basically counterfeit right now. How do we avoid that? Those may become more issues. Think about in terms of like where we get auto injectors and certain supplies we use for injections and such. Many of those in the United States come from overseas manufacturing. Hypothetically, if worse things do happen in the global supply chain, those become shortages, how will our specialty pharmacy markets react when they can't get the devices or get the drugs in at the end of the day? How do we as pharmacists respond? And what markets will we turn to get therapeutic agents for patients that demand this, but we cannot fulfill it because our traditional drug supply chain has crashed overnight because of potential global catastrophes? And I think it's where, as we go on, there will be some issues with that global supply chain, like determining, what do we have to keep safe and not keep safe at the end of the day. And I think most of our patients, at least within the US, are pretty safe from this at this current time. We've done a very good job not bringing this up. When I talk about this topic to my students and even other colleagues, this is not something they ever think about. They say falsified medications. They're like, what's that? Is that like divergency? Someone like stealing medications or something? Like, no, it's actually not the real drug. Like, why would that happen? There is a bias, at least within our population, that should never happen. So if this does start happening, I think it leads to, let's say the next slide, we'll see more clamoring from the consumers saying, hey, why is this going on? How do we fix it? And that's why I come back to, I think that's the biggest problem right now is if it's not broke, don't fix it. Unless there's clamoring that there are issues are coming up, there's no reason to change regulation. No one has to chase after anything at the end of the day. So yeah, I'll just reemphasize the points that Lisa made. I think that's really where we're at this current time, at least with the United States. Other countries may be very different. And I think that's going to be key, is what is going on within your nations will determine what is the level of regulations and rollouts that you want to engage upon. And at the end of the day, the cost barrier to at least maintain a level of optimization of therapy that makes sense then. So I'll close with that.
Well, thank you very much for both of you to address this topic. And, you know, one of the things that I didn't hear you say, but I know sometimes it's a challenge, is are patients buying through the internet? So there's still a lot of our patients that need to be counseled not to buy medications that may not have the security systems in place. So just wanted to put that out there, because we do see a lot of falsified medications. So with that, this wrap up our panel discussion and our event today. We heard a lot about, you know, digital health and its impact in pharmaceutical care from different angles. We talked about regulatory, we talked about practice issues, we talked about education implications, but also we talked a lot about economic implications. And again, you know, who is going to pay for this and what is the reimbursement mechanism for the pharmacists? So again, it does have a lot of implications in a very varied way. I'm going to ask Patricia to join me and probably share some of her thoughts and comments, and then she will wrap up the event. So thank you again for all your participation.
Well, as Magali said, pretty much all has been said. However, I would like to summarize and say that even though different countries with social and economical differences were presented today, we can say that the drivers, challenges, and initiatives are pretty much similar and all focuses on patient care, right? Regarding that, we can find different applications and different resources available for patients in all of the countries, and we can highlight some other initiatives going on in Chile, for example, with this electronic prescription, as well as in Uruguay with this COVID app that for sure has helped people with the pandemic. Regarding barriers and challenges, costs again come as the main barrier for implementing technology among not only patient adherence, but of course, falsified medications. Yeah, that's mainly. And I would like to add as well that drivers are mainly what were mentioned here were metrics and access to medications and improving patient health care. Would you like to add something, Magali?
Yes, the only thing I wanted to remind everybody is that there will be a report that will be launched in December from FIP, which will include summary points and recommendations from all the regions. So we encourage you to look up for that in December, because it will be a very nice document that will summarize all of these lessons that we're learning throughout the region.
That's right. So to end this activity, we are super excited to invite you to the 80th FIP World Congress of Pharmacy and Pharmaceutical Sciences that this year is going to be hosted by the beautiful and amazing city of Seville in Spain, right? The Congress will take place from the 18th to the 22nd of September under the theme, Pharmacy United in the Recovering of the Healthcare. If you wonder, registrations are still open. And for more information, you can check our website, seville2022.fip.org. Also shown in the slide, I think, yeah. And if you like to see our upcoming events, you can check our website, events.fip.org, and to see the upcoming events that I've already said. And of course, if you want to go back to this activity of the Americas or the other ones already held. So yeah, that's that's it, I think, right, Magali? We've been through this interesting conversation. So now we would like all to thank you for your attending. And we'd like to finish with this activity and ask all of our speakers to open their cameras, please, and to wave bye. Yeah, I think we have.
Thank you so much, Patricia, and thanks
all of
everyone
us
on the
here.
call.
So thank you, everyone. Muchas gracias a todos. And have a good day, night, and so on. It depends on where you're seeing. Bye, everyone.
Bye,
Adios.
everyone.
Bye, everyone. Thank you so much for having us.